and has been a cardiologist. Has been a cardiologist, the doctor for 9 years, and a cardiologist for the last 2, working at the Mater Hospital, Wagga, and in Southwest Sydney. Although we won't say much about Southwest Sydney, considering the current situation. He grew up as a High Church Anglican, but of course, in Easter this year, was received into the Catholic Church at St. Peter's. He also, as part of his study, he did his honours in bioethics, hence the topic today, and his rotations in palliative care and heart transplantation during his training, and his ongoing work at a Catholic hospital. He's passionate about the pro-life cause and caring for patients from a Catholic perspective. So with all that in mind, we welcome Sam, and we very much look forward to hearing from him today. So in your own quiet sort of way, please make Sam feel very welcome. Or yours, Sam. I will be muting myself.
Thanks a lot, mate. Thanks a lot for that very kind introduction and for the pleasure of being able to give this talk today. I'll just share my screen and then we can get going. I've got some slides here. Okay, can everyone see that all right? Great. Okay, so yeah, today I'll be talking about working as a pro-life doctor, obviously from a medical perspective and my particular perspective, but I hope that this is something relevant to all of us, because we're all called to caring for other people, and we're all called to be pro-life as Christians. A lot of where I am now and my perspective on end of life, I do owe to St. Camillus de Lellis, and there's a picture of him there. So I was looking up for a prayer to start this talk with, and the Pope has put aside a prayer to Our Lady, Health of the Sick, and I was delighted to find out that St. Camillus de Lellis is actually buried at her shrine in Rome. So I'll start off with this prayer. I'll just move the Zoom thing out of the way. Okay, let us pray. O Mary, you shine continuously on our journey as a sign of salvation and hope. We entrust ourselves to you, health of the sick. At the foot of the cross, you participated in Jesus' pain with steadfast faith. You, salvation of the Roman people, know what we need. We are certain that you will provide, so that, as you did at Cana of Galilee, joy and feasting might return after this moment of trial. Help us, Mother of Divine Love, to conform ourselves to the Father's will and to do what Jesus tells us. He who took our sufferings upon himself and bore our sorrows to bring us through the cross to the joy of the resurrection. Amen. We seek refuge under your protection, O Holy Mother of God. Do not despise our pleas, we who are put to the test, and deliver us from every danger, O glorious and blessed Virgin. So today I'll be talking about what does it mean to be pro-life. This is something that applies to all of us, as I said, but I'll be speaking in particular from my perspective as a doctor, and my personal experiences. I'll be talking in particular about the need to have hope as a patient and as a health professional. Being a good doctor is part of being pro-life. Having a heart that sees. There's a very good document that the Vatican put out about euthanasia last year, and they stress the idea of doctors having hearts that see who their patients truly are, and following one's conscience as a health professional and as a Christian. Then I'll talk about some situations where being pro-life in the healthcare professions can conflict with the profession in Australia, and how to deal with this, in particular in settings of end-of-life care and reproductive medicine. I personally have had a lot more dealings with end-of-life care, so I'll focus a little more on this. So I'll start off with a case study just to give you an idea of what can happen on the day-to-day practice of being a health professional. Often we think about the big battles that occur in healthcare, but you've got to be able to deal with the little battles and the daily conversations to be able to approach the big issues. So I saw a lovely 85-year-old gentleman a few months ago. He presented to see me for his routine cardiology follow-up. He told me he was having symptoms of breathlessness, cough, and weight loss on a background of previous lymphoma, which was successfully treated about 4 years ago. He was telling me that he and his wife were relying more and more on their sons for assistance, which troubled him and saddened him. Sadly, his wife had had a recurrence of her lymphoma and had been given a terminal prognosis only about a month before I saw him. So I offered this gentleman, Mr. S, some investigations to determine whether or not his lymphoma had recurred, but he told me that he didn't want these investigations. He then proceeded to ask me if all of his tablets could be ceased, and he told me that he found a new GP that believes in euthanasia because he was keen to pursue that pathway if it were to become available in New South Wales. He told me that he believed that he had no value in his life and nothing further to offer at his age. So just think yourselves, if you were to hear someone tell you a story like this, what do you think would be the best response? Would it be A, tell him that he must accept all investigations that have been offered and all medications, and ensure that he's willing to undergo chemotherapy if his lymphoma has recurred? Should we B, cancel his investigations, but strongly encourage him to take his medications and dissuade him from considering euthanasia? Or should we C, allow patient to dictate all aspects of his care, as anything else would be paternalism? So I'll give you a few seconds to think through those options. Obviously, yeah, it's hard when you see someone like this when you're put on the spot, but essentially a lot of the response of medicine and of people to death is motivated by fear and a lack of hope and a lack of value. And often an excessive medical response is the flip side of the coin to a euthanasia response. So with option A, it was clear from discussing with the patient that if he did have lymphoma, he wouldn't be able to tolerate chemotherapy. He was quite old and frail, and that treatment would have been excessively burdensome. So to force him to go through investigations for a treatment for a condition that he wouldn't want to be treated for wouldn't be right. As is option C, there's some currents in medicine which say that the doctor shouldn't invest any of his personal opinions on the patient. But medicine is a personal and caring profession. We're not just technicians, we're people. And we do bring part of who we are into how we treat patients. So C is also wrong. So option B is what I chose in this case. I did cancel his investigations into lymphoma because I knew that treatment for that would be excessively burdensome. But I did strongly encourage him to take his cardiac medications because they were keeping him alive, essentially. And I had a chat with him about not considering euthanasia. The first person I considered when I saw this patient was this guy. I don't know if you've heard the story of Sir Tom Moore, but he was the retired army veteran in the UK who, after living a quiet life at the age of 19, became almost world famous after raising millions of dollars for the NHS. And I tried to show this person in as general terms as possible that there's no point of a person's life where they're without meaning or purpose. There's no point where our lives suddenly become of no value. And I think he did take that on board, but it was a bit hard for him going through the sadness of what had gone through his wife. When we hear people tell us these things or ask us these questions, we have to look generally at what the underlying issue is. We have to be able to listen to them and care for them as individuals, not just look at the arguments they're putting forward, but look at what sort of person they are, what are they actually dealing with. So the great G.K. Chesterton put forward a quote that I think is relevant to all of us as healthcare professionals and all people. He was basically writing against the tendency of many philosophers and writers of his time to see life as being hopeless. In Dante's Inferno, they said that at the gates of hell, it says, "Abandon hope, all ye who enter here." And he thought that many people now had that attitude about everyday life. I think from a secular perspective, if you see how untrustworthy your colleagues can be at times, how inevitable death is, it's easy to see life as being futile. But if you're going to be a good clinician, if you're going to be a good healthcare professional, you have to abandon hopelessness and go against the grain of what our culture is telling us. And because of Christ and his resurrection, we are able to abandon hopelessness and have hope when things do appear to be the opposite. So all humanity is called to care. We all have a vocation to care for human life. And medicine in particular is a vocation or a profession called in particular into that general call that we all have. It's not just doctors who have to care for fellow humans, we all do. But medicine is a particular vocation based on that. One medieval statement said that the goal of medicine is to cure if possible, but always to care. Medicine is an encountering with suffering and death. We often see people when they appear to have the least amount of dignity that they have, when they are suffering the most, when they're often not in their right minds or not speaking as they normally would. And to be able to treat our patients correctly, we need to be able to have a hope and a perspective beyond what's just in front of our eyes. Some people have said that medicine is quite sacramental in its activity. The sacraments allow us to see the truth of the material world and also point to the fulfillment of all things at the end of time. Just as the water of baptism through the Holy Spirit cleanses us from sin, it's an indication that the original purpose of all water was to be cleansing and to offer us communion with God. Similarly, in medicine, we need to be able to see the truth of a patient. The idea of a patient's, the idea of human nature and human essence is something that's foundational to how you treat patients. When you see them in suffering and in situations where they appear to lack dignity, you need to know what it is you're trying to restore them to. What's the vision that you're aiming for? There are obviously currents in modern medicine that don't hold to a true human essence. For them, the goal of medicine is to just follow what the patient wants. Whereas we know as Catholic Christians that we do have an image of what a patient is meant to be, and we are able to offer care to restore them to that image. One Orthodox saint was given the message from God to keep his mind in hell and despair not. There are many circumstances that patients, humans in general, and doctors have where things may feel like they're hell, that all's going wrong, but we're called in those circumstances not to despair. One example of this I particularly thought of recently was Cardinal Pell, who was put in prison, and it appeared that all was against him, and it would have been easy to despair in that circumstance, but by having hope, he was able to get through that circumstance. So there's a lovely quote by St. Bonaventure which basically links the idea of hope with truth and virtue. Basically, because we believe in the resurrection of Christ, we believe that we will be participants in that resurrection at the end of time. And because we believe in the resurrection, we believe that the body is valuable. From a secular point of view, it's easy to see the body as something that's not of value, that's eventually going to die. Whereas when we believe in the resurrection, we know that our bodies and souls will be reunited one day. And we know that who we are as a human person is a combination of body and soul. Because we have this assurance, we can then have peace, despite being faced with death. And St. Bonaventure rightly points out that it's only when you have perfect peace that you can grow in virtue. So hope, therefore, for the Catholic doctor is based in the resurrection of Christ and informs his anthropology, his peace, and his virtue. Talking about having hope is particularly relevant, I've found, to the euthanasia debate. There are arguments out there that say euthanasia should be allowed because people in unbearable pain should be provided a way out of that pain. But most studies looking into the area of euthanasia show that it's not unbearable pain as such, or unbearable physical pain, that's the reason people request euthanasia. The reason most people request euthanasia is because of something that's been termed existential suffering or metaphysical pain. Palliative care can often address pain itself quite well with medications, but people's feelings of hopelessness and worthlessness are often more difficult to deal with. And often people look for shortcuts out of that, when really what they often need is people who care about them, a supportive environment in a hospital, a family that listens to them. And often the people that are requesting euthanasia don't have those things. Pain itself, though, does have a physical and a cognitive component. We perceive pain differently based on our mental states and how much hope we do have. People can go through significant pain, but if they can see a meaning behind that, if they're in a good mental and spiritual frame, that pain can be dulled. So there's a very interesting study from 2014 where they looked at some end-of-life cancer patients who were outside of hospital being managed as they came to the ends of their lives. These patients were asked to report what was going on as they approached death. Patients in both groups, so those who requested euthanasia and those who did not, both reported unbearable suffering. So 94% of those who had euthanasia, who requested euthanasia, had some form of unbearable suffering. 87% of those who didn't request euthanasia also had some unbearable suffering. So there wasn't a great difference there. But what the cause of that suffering was quite different. So unbearable pain as such was only present in 5% of patients who requested euthanasia, and only in 10% of those who did not request euthanasia. Whereas an unbearable need for help with housekeeping was present in 66% of people who requested euthanasia, and only 33% of those who did not request euthanasia. So in this group of people, looking at better housekeeping and support would have been a much better idea than euthanizing the patients. I don't know if any of you know where this scene's from. I don't know if any of you have seen this movie, but this is Moby Dick. And this is a particularly poignant scene, which I think defines what goes on in the movie. Essentially, Captain Ahab there on the right has been pursuing the white whale, seeking to kill it for the suffering as brought upon him. He lost his leg in a battle with the white whale, and he sees the whale as his ultimate enemy, and also as an image of the universe or God being against him, and he seeks vengeance for the pain that he's been through. But somewhere along his journey, he bumps into Captain Boomer here. We all know that boomers are very good, and Captain Boomer was the captain of another ship, and Captain Boomer had lost his hand in a battle with the white whale. Captain Ahab asked Captain Boomer where the white whale had gone and how best to kill him. Captain Boomer laughed though, and he said, he's a dumb creature. God has spared me from losing my life. I've only lost my arm. I think we should be grateful for being spared worse things, and we should move on. Captain Ahab laughed at him, saw him as being insane, and continued to pursue the white whale. I think the lesson from this story is that suffering can bring about very different responses in us. It can make us bitter, or it can make us better. And this is true both for patients and physicians. So we need to be careful how we perceive pain and suffering, and that will guide our response to it and how we live. I remember the very first two patients I saw as a medical student when I was unleashed on the wards. Both of them had what I thought was unbearable suffering, situations that I'd never seen before. But their responses to it were very different and inspired me quite a lot. The first patient I saw had an autoimmune disease, and it had affected his eyes. He'd gone blind literally overnight. But even though he'd gone blind, his ex-wife had come back to look after him and had agreed to move back in with him. And he worked as an ice cream salesman of all things. And he told me that his work as an ice cream salesman would not be impeded by his blindness. In fact, he expected to have greater sales and greater support from people despite his sufferings. And he knew that his ex-wife was going to put in more help. So not only myself, but many of my colleagues noticed how hopeful he was in this situation. I know it's hard to believe that someone who loses their eyesight could be hopeful, but he was. The second patient I saw, however, was very different. He was diagnosed with multiple sclerosis some years back, and he'd been admitted to hospital because he tried to take his life after an attack of multiple sclerosis. His attacks consisted in numbness and weakness in different parts of his body, and his mobility had been significantly affected. But despite this, he had a loving wife, loving kids, a supportive environment, but he couldn't see any hope in his circumstance. He felt demeaned by his lack of mobility. And the neurologist I worked for at the time said it was only a matter of time until he thought he was successful with his suicide attempt. So this was very sobering to me as a medical student, just to see how different people's responses could be to similar things. So we shouldn't see unbearable suffering or pain as something that requires euthanasia. We should see our response to it as what's important, and helping people with their response to it. So moving on to what I think is the next aspect of being a good doctor, or the good doctor, or being pro-life. Pro-life is actually consistent with good medicine and being a good doctor. If the goal of medicine is to save life and to care for people, then being pro-life is very consistent with those aims. According to the Hippocratic Oath, the goal of medicine is to help, heal, and benefit the patient, but first to do no harm and not to administer a poison. To be a good doctor, you need to be a good person. A doctor is not just a technician. He brings his personality into his medicine. And many of my colleagues have said we can train most diligent people to pick up the skills of a particular specialty, but it's hard to train someone to be a good person and to care for their patients. So to be a good doctor, you need to be a good person. To be a good person, you need to be a person of virtue. To be a person of virtue, you need a model, a source, and a practice for that virtue. And I think that's ultimately fulfilled in Christ. In Christ, we have and the saints, we have a model for our virtue. Through the Holy Spirit, we have a source for our virtue. And through practicing our profession and our Christian faith, we grow in those virtues. When you fulfill the goals of medicine, so healing, you treat the suffering of the patient so as to help the patient. You're not to eliminate the sufferer of the pain to get rid of the pain, which is what euthanasia tries to tell us to do. From a pro-life viewpoint, we can see that many practices that go against the pro-life viewpoint not only go against the goals of medicine, but they're also not good medicine for other reasons. I've had patients who've come to see me who are on IVF and contraception, and these often worsen cardiac issues. IVF can lead to fluid retention, which can worsen the situation for patients with heart failure. And many contraceptives worsen palpitations. I can't tell you the number of teenage or young adult women who've had palpitations, and it's coincided with their contraceptive. Also, there's a link. There are some links between contraception, abortions, and a risk of breast cancer. So being pro-life and going against anti-life practices often fits with being a good doctor and good medicine. There's one particularly useful form of ethics that we were taught in med school that I think links very well with the idea of pro-life being part of being a good doctor. There's a framework of ethics called virtue ethics, and this sees good practice as practice that results from the virtuous moral character of the doctor. So going into a few nitty-gritty details of virtue, virtue involves fulfilling one's telos or vocation or goal. Everything in life has, all living things have an essence and a vocation, and often one's vocation is based on one's essence. A chair, its vocation is to provide the means for someone to sit on it. It's not fulfilling its vocation if it doesn't allow someone to sit on it, and it's therefore not a good chair. Similarly, to be a good doctor, you have to fulfill your vocation. And the vocation of medicine we already described was healing people, was saving life. So if you fulfill your vocation of saving lives and healing people, you'll grow in virtue. It's a lifelong practice. However, if doctors whose goal is to save lives are required to end lives, that directly goes against the vocation of medicine. It goes against the telos of being a good doctor. And if you're not fulfilling your vocation, if you're going against your vocation, you will not grow in virtue, and it will be harder for you in testing times to save someone's life. Often as a training doctor, you have to attend cardiac arrests on elderly people, and it's very stressful and requires a lot of effort. If you're used to ending people's lives, it will make it all that harder to put in the effort to save people's lives when it's really required. One Catholic philosopher told me how he went to a legal meeting with some lawyers and philosophers about what requirements were required to the law if euthanasia became legal. He said most of these lawyers were supportive of euthanasia becoming legal, and they wanted to change the law to make euthanasia not a form of murder. And he asked them, if this becomes legal, will you then as lawyers administer the lethal injection? And this frightened them and shocked them. They said, oh, no, we're not going to administer any lethal injections. We want the doctors to do that. But obviously that's quite unfair to make doctors whose goal is to save lives also end lives. So moving on to the next aspect of being a pro-life doctor, the heart that sees. So there's a very good document I recommend any health professional to read from the Vatican that was put out a year ago, called Samaritanus Bonus. And basically this was a response to euthanasia and lack of end-of-life care, particularly in the setting of the pandemic. And they took for their inspiration the parable of the Good Samaritan. So the parable of the Good Samaritan is an image of Jesus and an image of fallen humanity. And Jesus told that parable because he was asked, who is my patient? Sorry, who is my neighbor? As physicians, it's very important to ask ourselves, who is my patient? We need to be able to see people that our culture tells us not to see as our patients. We need to have a heart that sees who our patients are. We need to see the image of God in our patients. It's not just a philosophical problem as to who we class as humans, or a problem of who we believe to be humans. It is that, but it's also a problem of the heart. Do we see our patients as made in the image of God? Do we see them as our patients? I remember a cardiologist I worked with took me in to see a patient who had cardiac issues, and he'd become unconscious. We knew that he probably wasn't going to wake up again. And he said to me, we're no longer treating this fellow. He's not our patient. His family are the only people we're looking after. And he didn't address the patient when we went into the room to see him. And that saddened me greatly. Here we have, someone who's unconscious at the most difficult part of their lives, and we can't even call him by his name. I think if we're truly going to follow in the footsteps of Jesus, we need to see people whose dignity is most hidden, who are going through the most difficult parts of their lives. We need to see them as our fellow neighbours. We need to see them as our patients. And this was how Christianity changed the Roman Empire and influenced the world. The early Christians of Rome were a shock to many around them, not only because of how they treated the sick and the suffering, also because of how they treated the dead. They showed respect and care even for the bodies of the dead, which we know is a work of mercy. So if we do see our patients as who they really are, people will notice that. And this isn't just an issue for the big pro-life issues, it's an issue for everyday medical practice. Do we see unconscious patients, organ donors, patients with dementia, irritating patients, or psychologically disturbed patients as our patients? It's easy to lose care for these people and be irritated by them. But if we truly have the heart of Christ, we'll be able to see them as our patients. And only when we do see them as our patients will we be able to offer the care they deserve. So, as I mentioned before, we not only need to believe that our patients are made in the image of God, we need to be able to see that image of God in each patient. It's an issue not just of the mind, but of the heart. As doctors, we're also called to be incarnational like Christ is. Christ became what we are without losing what he is. Similarly, we should be able to identify with patients. We should be able to see them as one of us without losing what we are. We need to have compassion with them. True love involves suffering. And there's some great quotes from Edith Stein or St. Teresa Benedicta of the Cross and St. John Paul II, basically saying that to be able to see the truth of something or to see the truth of a patient, you need to have love. True love should mix with truth. Love without truth isn't true love. Similarly, truth without love isn't really truth. And true love involves suffering. As St. John Paul II said, whoever truly loves does not stop at the prospect of suffering. He accepts communion in suffering with the one he loves. And in fact, when someone is in a worse circumstance, we should love them even more. G.K. Chesterton said, the point is that when you do love a thing, its gladness is a reason for loving it, and its sadness a reason for loving it more. He was referring to patriotism. So if your country is doing badly, you should be supporting it even more. And I think that goes with patients. If a patient is suffering, if they're unconscious, you should be caring for them even more. So love and compassion allow the truth to be witnessed. Just as a patient's perception is affected by the virtue of hope, so they can get through suffering by having hope, so a doctor's perception is affected by the virtue of love. If we do love our patients, we'll be able to see who they truly are. This is just a picture of Jesus raising Lazarus. In a lot of the old paintings and icons of Lazarus, the people around him are covering their noses because he stinks. I think this is a good image for medicine. Even when the people we're looking after stink, we've got to look after that. We've got to look past that and see their dignity and recognize that Christ can still raise them up from the grave, even when they do stink. So Jesus said, blessed are the pure in heart, for they shall see God. An encounter with a patient is an encounter with Christ. Um, Growing in virtue allows us to be pure of heart. And when we are pure of heart, we can perceive the truth of a patient. When you perceive the truth, your conscience is enlightened. And when your conscience is enlightened, you have greater freedom to act according to the truth. Also, when you see things truly as a doctor, you recognize how powerless you actually are a lot of the time. And when you realize how powerless you are, you see how much of medicine is actually from God. It's actually God that sustains the patients. It's actually God that dictates life. A lot of the practice of medicine that's not motivated by a pro-life point of view sees life and healing as in the hands of man. If we see someone in suffering, we feel that we have to be the ones to solve every problem. We have to be the ones to solve death. And often that can lead to excessive medicalisation or to euthanasia. I've worked with several doctors who say that palliative care is not an option, it's giving up. But there does come a point where what we as humans have to offer falls short. And it's up to God, into his hands, we have to commend the patient. We know from scripture that God isn't just the source of life, he sustains all life and all creation. So we might think we're upholding our patients, but it really is God that is. I'll just move on from that. Okay, so moving on to the last aspect that I think is important as being a pro-life physician, so following one's conscience. So as said before, the doctor isn't just a technician who can go and do his work, do what he's told, and then go home and not be affected by it. The doctor's a moral agent with a conscience. And if doctors are being forced to do things that go against their conscience, that will affect who the doctor is as a person. Conscience is the consideration of a specific case in light of one's moral knowledge. People's moral knowledge can be imperfect. We are fallen creatures, but we do have a duty to follow our conscience. Pope Francis, I'll just move my Zoom thing so I can read that. Pope Francis said, sin, also for those who don't have faith, exists when one goes against one's conscience. To listen to and obey it means, in fact, to decide in face of what is perceived as good or evil. And on this decision pivots the goodness or malice of our action. Even on those who don't know Christ, he knocks at the door of their conscience, trying to speak to them as to what is right and what is wrong. People may choose to ignore that over time, and people's conscience can become darkened by sin. Notwithstanding, Christ is still there trying to tell us what's right and wrong. And when we go against our conscience, that is sinful. There are many pressures in medicine this day for doctors to go against their conscience. And this isn't just in the issues of euthanasia and abortion. It starts even as medical students and on a day-to-day basis at times. Many junior doctors or medical students do feel pressured to do things that they deep down know aren't right. I know other medical students and myself, at times we had physicians who tried to pressure us to do examinations on patients while they were unconscious that we hadn't obtained consent to. And many of us did say that we wouldn't do that. But it can become a slippery slope when you're pressured into doing things you know aren't right by your seniors. It's easier the next time to do something that's more immoral. It's difficult for a doctor to be faithful to his conscience in the big matters, in matters of life and death, when he's not been faithful in resisting the daily pressures against his conscience. Because of our consciences and in following them, we do have to go through, as Christians, a form of martyrdom in our work at times. Now, in the writings of the church, they talk about something called a red martyrdom and a white martyrdom. So at times we may be asked to give our lives, or in medicine, our profession. There may be times where we're asked to do something greatly immoral, like euthanasia. And in those circumstances, we do have to say no. And we could lose our profession in those cases. But those cases, thankfully, at least these days, are rare. What is more common is the white martyrdom of everyday work, or the church talks about white martyrdom as sacrificing your desires to grow closer to Christ. working in healthcare, it can be easy to join in with discussions that make fun of patients when they're not around, or that mock your seniors. It can be easy to have despair or to speak negatively about patients' outcomes. All these little things, the words you say, the attitudes you have, these are actually very important in the long term. And going through the white martyrdom of rejecting it when someone says these things will make you stronger for when you may one day have to face a big issue. I don't know if any of you know what saint this is a picture of, but this is St. Benedict Joseph Labre. He was a saint who was rejected from multiple orders. He never got to enter a particular order, and in the end he became a vagrant beggar going around from shrine to shrine for the rest of his life. He died at a very young age, but he was renowned for how bad he smelt. He was seen by most people as being a tramp, but at times when he was praying, people saw a light around him. And when he died, the children of Rome proclaimed him as a saint. He's a type of saint that in the East they would call a fool for Christ. Sometimes as health professionals, we do have to be fools for Christ. When you do the right thing, you might look as a fool or as a peculiar person or as a stranger, but St. Paul does call us to be strangers and pilgrims on earth, to be a peculiar people and at times fools for Christ. Unfortunately, some legislation in Australia now opposes the idea of conscientious objection, particularly in the abortion sphere. If someone comes to you for abortion, you are required to refer that patient to a practitioner you know does support abortion. And this is quite deleterious to good medical practice and something that we may have to avoid at times. Okay, so moving on from my perspective of what it is to be a pro-life doctor, I'll talk about a few situations where healthcare professionals can have conflicts between what their views are as pro-life doctors and what the profession tells them. So this is a picture of when I worked at the Sacred Heart Hospice, the palliative care hospice at St. Vincent's Hospital. Now, I think cats provide a much better palliative care than many people. Cats often know when people are dying, and they often sit by patients for 2 or 3 days before they die. And that's part of what good palliative care is. The Christian response to the mystery of death and suffering is to provide not an explanation, but a presence. Unfortunately, in the end, they got rid of the cats because they did scratch a couple of people, but that's another story. But yeah, in end-of-life care, as this Vatican document says, being present with people, offering them hope and support is more important than giving them a solution or an answer to the problem they're going through. Just as in the pandemic, when people are going through difficult times, often they just want someone to be with them. Some of the saddest things I've seen in my career aren't necessarily people dying suddenly from an issue that we wish we could have treated. Often some of the saddest things are bad deaths. Bad deaths are things that often scar healthcare professionals, and I've seen situations where other health professionals have needed counselling for what they've seen. I had one patient who had a form of leukemia, and she was a dedicated practicing Catholic, but the haematology team said that they didn't believe in palliative care. They didn't believe in giving up or in supporting the patient as she came to the end of her life, and they kept giving her more painful forms of chemotherapy. They tried one form, then a worse form, and then a worse form. And in the end, she suddenly died at 3 a.m. one morning without any family around, and she didn't get the last rites. And this was well before I became Catholic, but that really shocked me to the core at the time, and really hit home to me that not only do we need to be throwing stuff at people to cure them, while we're trying to cure them, we need to care for them as well and think about all the other things that are going on. Think about the things that are more important to them. For this lady, at her final moments, having her family nearby and having the last rites would have been far more important than a fifth-line chemotherapy agent that had a 2% chance of saving her life. I had another patient who, this is a better ending, he had a severe heart condition. He was coming to a stage where he was starting to go in and out of consciousness. And the surgeons came to see him, and they wanted to try a newfangled device that was going to be an 8-hour operation that was going to give him maybe a 40% chance of living an extra few months. But this particular operation they wanted to do because they just had a presentation on how this technology had been updated, and they wanted to get practice at using this technology. My personal opinion is that they didn't particularly care about the patient in front of them. They cared about doing something that was interesting and amazing. And he wasn't fully explained as to what was involved in that. One problem that we often see in medicine these days is lack of truly informed consent. Often when people are offered very burdensome treatments, they're not told as to what it truly entails. But yeah, he was offered this very difficult operation with a small chance of success without being told what the implications of that were. And he and his wife agreed to that. And being just a lowly registrar at the time, I tried to tell the surgeons that I didn't think it was in his best interest or what he wanted. But myself and the junior doctors with me were basically laughed at, and we were told that was only our personal perspective. We were bringing our subjectivity onto the patient. But as I said before, medicine is a personal profession. We have to bring our personality and our connection onto it. In the end, a few hours before he was due for the operation, his wife quietly said to the doctor under me, "We don't really want this. Can you stop this?" And so the doctor under me brought me to see him, and we had a chat with him and his wife. He was on the verge of being totally unconscious by that stage. And she actually said to me, she said, "It's more important that he dies a good death than that he has a small chance of survival through this treatment." So we quickly got the palliative care doctors to see him. They shipped him over to the palliative care ward. He was surrounded by his wife and his family, and he died a peaceful death just a few hours later. And his wife wrote the most lovely letter to the doctors on my team and myself, saying that this mattered. This was probably the thing in his whole care that mattered most to her. So basically the message from this is that we need not to just have blinkers on thinking about saving people from death. We need to be caring for people and seeing what their real issues are. As I said before, paradoxically, often extremes of care and euthanasia are two sides of the same coin. So palliative care is something that has often declined in nations with euthanasia. If people see the ending of life as the only response to pain, often they don't think of alternatives. If euthanasia should become legalised in New South Wales, a strong palliative care service should be encouraged. And this is so that it's an alternative to euthanasia and a bulwark against it. People need to know that there's something better available, something that provides true care. So responses to end-of-life care. So we need to provide accompaniment and care for patients. So the family is very important to the dying patient. One thing that when Sir Tom Moore, the English former army veteran, died, his family got to be with him when he died, and they started a campaign at the time saying that every patient who dies of COVID needs to have someone with them. In fact, every elderly patient who dies needs to have someone with them. And I think this is very true. People who are surrounded by their families when they're dying don't have the same despair that other people have often. The Vatican document speaks not only about the importance of family, but of hospices. So good palliative care settings that can provide care from a personal point of view, and the importance of the church and priests offering the sacraments. Patients need to be provided with the option of palliative care. Sometimes patients don't know that there's an option for palliative care or an option for treatment that supports them through the end of their life. And yes, St. Camillus Stellellus, for me, really is the father of palliative care and of a good death. He was a saint who had a gambling addiction and ended up in hospital and saw how bad care was for the sick, and he set up his own system of care. He really ensured that not only did the dying get good care, but they were given the last rites and a good Christian burial. Moving on to some other end-of-life or other conflicts that the pro-life doctor can have. I'll just briefly touch on the last few issues. There's something called pre-mortem intervention. So when someone is deemed an organ donor or a potential organ donor, often in hospitals, they're given infusions and treatments to make their organs more readily transplanted. But often these treatments can be quite demeaning to the dignity of a patient. They can often get in the way of the patient having their family nearby and can unintentionally hasten the patient's death. This was something I came across a fair bit when I was doing a heart transplant rotation. The thing that troubled me about this is that patients were being used as means to an end and not as ends in themselves. They were being used for someone else's benefit and not being treated with dignity at their last moments. So in these circumstances, I think a caring family, once again, is a great support against doctors, overly zealous doctors treating patients like this. If you have a family that is surrounding the patient and is advocating for them, they're less likely to be treated as a means to an end rather than an end in themselves. And I think from a doctor's perspective, having true compassion for your patient will prevent you from trying to institute treatments on them that only really affect their organs rather than who they are as a person. Touching briefly on euthanasia again. So I've experienced this as family requests, as patient requests, and as physician requests. I saw a lovely elderly lady. She was a Christian, a Methodist, I believe, and she had had a fall and was unconscious, and she was close to death. And her nearest relatives were her niece and her sister. And they called me in to see them at 6 p.m. one night. And they were practicing Christians as well. But they said to me, look, we need to get home in an hour. We've got something on. Can you give her an extra dose of morphine so she dies before we go home? That obviously shocked me. Obviously had to explain to them that that's not right. We can't do that. But also had to explain the true purpose of palliative care and things like morphine. There's a lot of confusion out there as to what the true purpose of palliative care or things like morphine is. Some people think that it's being used to expedite death and is just another form of killing people. And their argument is that, well, if we're killing people with morphine, why can't we kill them with drugs? But no, that's not the purpose of palliative care or morphine. There's something called the doctrine of double effect in ethics, which basically says that you can give something to help a patient, even if it may hasten their death, as long as you're giving it from a true motive, as long as your intention is to care for the patient. And in fact, a lot of research shows that when you give people good palliative care, morphine and other things, sometimes because they're in less pain, sometimes they do live longer. So there's a lot of misunderstandings there from patients and doctors as to what the purpose of morphine and palliative care is. In this circumstance, thankfully, because the law backed me up and my team backed me up, I was able very blankly to say to the patient's family, no, I'm not doing that. But there could come a day where that may be more difficult. I had another situation where there was a lady dying of lung cancer, and the doctor who was looking after her was pro-euthanasia, and he charted doses of morphine which were well in excess of a pain-killing dose. And he asked the nurse, I was just a medical student at the time, and he asked the nurse to give these doses. Thankfully, the nurse gave only very tiny doses. Despite what was charted, the doctor couldn't bring about her euthanasia because she just wouldn't give what he told her to do. And I've heard some Catholic policy writers and philosophers say that there's a lot more hope that nursing will prevent euthanasia if it comes in than medicine will, because nurses often work as a unit. If a nurse is under pressure, the whole profession supports them, and they don't like to be dictated to by doctors when they're trying to tell them to do the wrong thing. In this case, the nurse did the right thing and refused what the doctor said, whereas sometimes doctors can be pressured by careerism or their seniors to do the wrong thing. So we need not just to look at what doctors are doing, we need to look at nurses, families, and other defences against euthanasia. So just thinking about some of the bills that have gone through and that are going through at the moment for euthanasia around the country, The Victorian legislation at the moment allows conscientious objection. So you can say you don't want to be involved in any euthanasia and you don't have to refer a patient. But this may change over time, sadly. The South Australian legislation is similar, but they only brought in this provision as a late amendment to the bill. In the Queensland Parliament, that they'll be debating a euthanasia bill in September, I think it is. And at the moment, it does not have provisions for conscientious objection, sadly. From a general point of view, we need not only to think about what doctors and nurses are doing, we need to think about support from colleagues, pro-life organisations, medical indemnity providers, politicians and others when it comes to these debates. So I'll move on in the interest of time. So looking at reproductive medicine issues, so contraception and IVF. So I have been asked at times to, and I know colleagues have been asked to give these on an inpatient and an outpatient setting. And it's obviously something as pro-life doctors that we need to refuse. When I've talked to patients about these as a cardiologist, I've explained to them the medical effects of these. They're often not good medicine, and they're often not good for people with cardiac problems. And when patients can see that you truly care about their health, they'll often listen to your perspective. It's important to offer patients alternatives. I had a patient just a few months ago who was asking about having IVF. And because I'd spoken to some people at St. Peter's who know people who offer pro-life alternatives to infertility, I was able to give the patient the details of this doctor, and they were over the moon. They're like, oh, someone who's actually listened and cared for me, someone who is able to offer me something other than just bombarding my body with hormones for IVF. So if you can show that you really care, that you're really listening to them and you're offering them an alternative, people will listen to that. From a broader level, when people ask you about these things and you don't feel in a position to refuse, you need to remember that you do have support from colleagues. There are organisations and institutions that can support you. And ultimately, we need leaders and courageous physicians to stand up against things like this. Often in the area of reproductive medicine, problems in society manifest as problems in medicine. And it may only be that when these problems are solved, that the problems in medicine are solved. So things such as a distorted understanding of sexuality, a utilitarianism, using people as means for an end rather than as an end, and poor decisions by leaders who care more for opinions rather than the truth. I'm sure there's a lot of people at the parish who can speak more to the issue of abortion than me. It's not something I've dealt as much with, thankfully, in my aspect of medicine, but it is an issue that many physicians do come across. So the current legislation in many states, including New South Wales, threatens to thwart the practice of medicine according to conscience. It doesn't allow true conscientious objection because it forces doctors who don't believe in abortion to refer patients. From the Vatican document, things they recommend are the ongoing provision of care. You need to show to patients in difficult circumstances that you do care for them. And if you're not offering abortion, it doesn't mean that you're not caring for them. There are other things you can offer. You need to show that that you're there to accompany them through these difficult moments, that there are other resources available, and that there are alternatives available. So moving on from that, in summary, a pro-life doctor should be a virtuous doctor. The virtues of faith, hope, and love are foundational to practicing medicine from a pro-life perspective. And a pro-life doctor should not only know that all persons are created in the image of God, they should be able to see that from the heart. The Christian response to the mystery of death and suffering is to provide not an explanation, but a presence, and a better understanding and the strengthening of palliative care services, I think, will be very important moving forward, particularly in euthanasia debates. So, and encouraging strong families, strong palliative care, and strong organisations that support conscientious objection is important, particularly if legislation changes in New South Wales. So, I want to thank you very much for your time today, and God bless. Thank you.
Sam, might just get you to stop sharing your screen for a second once you're...
I'm just trying to get it off.
Technology. Brilliant.
Sorry, mate, I'm just
Up to date with all the latest medicine, but not with the Zoom.
How do you get out of? How do you get out of?
You should just be. It should be well, at least depending on the computer, but you should be able to. There should be you go to the top of the screen. There should be a stop share, sort of a red button, as you wipe it.
Okay, did that work?
No.
Surely an admin can override this.
Oh.
Okay, you did it. Well done. Okay, Sam, first and foremost, that was absolutely sensational. Thank you for the depth that you went to in that presentation. Thank you for the courage that you show every day as a pro-life doctor when both the parliamentary and even your own profession doesn't support you in what it is you're trying to achieve. So thank you for your courage in that. I'll save my final thanks though for right at the end, because I want to allow a little bit of time for questions.